All right. Hi, guys. So I did my diverse and vulnerable population on the LGBTQI community. I work at a psych hospital called Columbus Springs, Dublin, and I work on a unit that mostly specializes in anxiety, depression, personality disorders, some dual diagnosis. Um, and we see a lot of diverse populations come in through our doors. But one population that we see in particular, at all times, we always have this population there, and it's a heavy number of the population is the LGBTQ community. So I chose to interview one of my coworkers named Sarah Elliott. She is the lead social worker on the unit. So she does a lot of the intakes and the discharges and things like that. So I'm going to go ahead and share screen and share my PowerPoint with you guys. Okay. So this is just a fact that came from the Milford article. Individuals identifying with the LGBT community have significantly higher rates of mental health conditions, substance use disorders, and suicide attempts. So that this fact alone is probably why we see a big influx of this community on our unit where I work. So the engagement part of it, when I spoke to Sarah, she said to always ask the client what pronouns they prefer. That's very important, and it's showing a sign of respect. And we want to make sure that we use the correct pronouns when we speak with them. And she also said it's very important to be open and self-reflective about any biases or prejudices you might have about this population. So that's obviously not something that you're going to say out loud to the client, but you just want to be intuitively self-reflective about this population. Assessment. She said for assessment, there's not a lot that we do differently because we have a specific kind of standard of care that we have to follow. We use a basis 32 for every individual that is admitted. This is still used. You might pay more attention to substance use questions or self-harm since these problems can be prevalent among this population. We also have with the therapist a process of collateral calls, and those calls are made to an individual's family or friends. We obviously have to have a release of information. We have to ask the client first. We can't just call whoever we want, whenever we want. But these calls are important because it gives us information about how the client's behavior has been up until admission. So have they been acting differently? Have they been using substances more? But the problem with this population can be that the family is not supportive, that the family has abandoned the client because of their own values, or they don't agree with the client's lifestyle, or perhaps the client has just come out as transgender and their family is not accepting, and that might be why they are seeing us. So we have to, Sarah said, we have to kind of be very aware of this, very sensitive about it, because the clients can be sensitive and it can kind of trigger them. And we have to try to maybe find friends if family members aren't available, just so we can talk to them about how the client's behavior has been. The intervention part of it, it's very important to make the client the expert in this area. And in a few slides, I'm going to share about cultural humility, and that really, the article that I read about that really ties into what Sarah was saying about the client being the expert. It's very connected. You want to ask what their coping skills are, ask how they want to be helped. Do they take medication? Have they ever experienced panic attacks, anxiety attacks, anything like that? We want to know all of that information. There's not a one size fits all intervention plan. However, we do have 2 psychotherapy groups per day and about 3 to 4 rec therapies per day that sometimes they go outside and play games. Sometimes they color, sometimes they create crafts. There's also a horticulture group where they go out and plant flowers and stuff like that. So the patients usually really enjoy those groups, and we usually tell them, we really want to see you attend those psychotherapy groups because that's where you're going to learn new coping skills, and those will help you. The evaluation part, this stays somewhat the same. We use the basis 32 at the end of the client's stay with us too. However, we must also take into account what experience they have had, the traumas they've endured, and how might this affect their recovery. So we do need to take those things into consideration with their evaluation. And really, we only evaluate how they did for the short-term stay in our facility. They usually only stay for 7 to 10 days. So their recovery really begins when they leave our facility. And we want to make sure that they have those appointments set up. They have a therapist, a doctor that they can get into contact with. Okay, this is the part about the importance of cultural humility that I was telling you about. I found an article entitled Teaching Cultural Humility for Social Workers Serving the LGBTQI Aboriginal Communities in Australia. So this wasn't, it's by Bennett and Gates. This wasn't an article specifically about our country. Obviously, it's based in Australia, but they had some really, really good information and kind of processes in this article that I really liked about cultural humility, because I think that's one of the most important things when we're talking about diverse and vulnerable populations. So some things I learned: cultural humility and actively listening to the client places the social worker in a less authoritative role, with the client being positioned as more knowledgeable than the social worker. Cultural humility promotes practice skills and techniques that support cultural appropriate interaction designed to reduce the worker's need to master the wide range of differences that exist in communities. So we are not the masters of these communities, that the client is, and the client is going to have different experiences and different things that they've gone through. And like I said, it's not a one size fits all. So it also said social work education must start to be a proactive with regard to assuming that many students bring with them outdated racial prejudices, white privilege, fear, mistrust, and lack of knowledge and understanding of the complex layers of access, equity, discrimination, and abrogation of human rights to marginalized communities. So this is saying, it's not saying that we're all prejudiced, that we're all, racist. It's not saying that. But if we are not a part of that community, we don't know firsthand what that community might go through. And then consequently, social work education needs to be based on participatory model that recognizes the importance of lived experiences. Participatory education can only be achieved in collaboration with LGBTI communities to affect a more culturally appropriate and effective practice framework. So that means we need to work with these individuals. And this is for any community and any vulnerable population. We must work with them and make them the experts. We must never reach a point in which we think that we know everything there is to know about a specific population. Each client comes from their own lived experiences and traumas, as I've said before. And then in Paul Milford's article that's entitled 3 Things to Know When Working with LGBT Clients, he addresses these 3 things as discrimination they have faced, violence they may have endured, and mental health issues that might be present. So these are just some more facts to kind of understand the vulnerability of this population. Though every state must now grant LGBTQ population with the right to marry, it was not that long ago that this population did not have those rights, and this may still affect this population. He also addressed the issue that not every state has laws preventing employers from discriminating against a person due to their sexual orientation. So I'm not completely familiar with the laws in Ohio. However, we might have clients that have faced discrimination and or been fired because of their sexual orientation. And in that state, it might not even be illegal. So if you kind of think about that, that makes them very vulnerable. And that can be very frustrating and make them feel probably very less in charge of their life. All right. Though individuals identifying as LGBT account for only 3.8% of the US population, they are victims of 21% of reported hate crimes. So that's a very large gap in those percentages. And then according to a startling report by the Center for Disease Control and Prevention, 46.4% of lesbian women, 74.9% of bisexual women, 40.2% of gay men, and 47.4% of bisexual men report being victims of sexual violence. Milford states that because of these statistics, we must assess our clients for a history of sexual, physical, or domestic violence, and using treatment approaches that take into account the experiences that the LGBTQ community will enhance the therapeutic milieu for our clients and help foster healing. So we really need to, this is part of the assessment part. We really need to assess for those instances of violence, domestic disputes, sexual violence, anything like that, because that's going to play a part in the healing process for our client. So we really need to know that part in the assessment. As far as mental health concerns, Milford addresses that LGBT men and women have a 2.5 times higher rate of mental illness or substance abuse than the heterosexual population. Sarah also addressed this in our interview. I kind of mentioned it at the very beginning. She stated that she reviews the basis 32 that we have given clients and looks for answers about substance use, or violence or domestic violence. She looks for those dual diagnosis answers because substance use problems can be prevalent. And because of that, we really need to take into consideration, is there substance use causing depression, anxiety, whatever it may be, or is it a true dual diagnosis? So there's lots of things that go into this, but I think the main takeaway from this is we really need to be culturally sensitive and have cultural humility in every part of this. And we really need to understand that we're not the expert that the client is. So I think that's the biggest takeaway from this. So thanks, guys. Bye.